Good afternoon, and thank you once again for joining this COVID-19 webinar series. It's a webinar series that's co-organized by the four parties: my employer, Ministry of Health and Wellness, the University of Botswana, Botswana-Harvard Partnership, and Rutgers University. So in today's session, we will be having updates from two DHMTs. We will have an update from Mahalapye DHMT and one from Tutume DHMTs. So we will get to hear their experiences so far in the response to COVID-19. The aim really is to find out what is happening on the ground from the implementers themselves, and really to learn from each other. So as always, we have a few housekeeping issues before our presenters can start. We have a mailing list that you can join so that you are able to receive invitations to these webinars every week. So the email that you email to is vindaba@globalhealth.rutgers.edu. These sessions are all over Zoom, and we would request that you please mute your microphone as the presenters present. You'll get a chance to unmute your microphone at the end and get to ask your questions. But if there are any questions that come up as the presenters are presenting, you may type your questions on the chat, and the moderators will monitor them and will respond to those that they can respond to. But otherwise, they will be responded to after the presentation. So these sessions are recorded and they are made available. After the session, we have a YouTube page where the sessions are uploaded. So that's the YouTube page. And if you have any suggestions as to how we can improve these sessions, or there's any presenter or any topic that you would like discussed in the future, please do email that same email address, vindaba@globalhealth, and help us with those suggestions. So that's the YouTube page. As you can see, it has different topics. There's clinical management, contact tracing has also been done, and there are other previous updates from DHMTs as well. We have a very important website, the COVID-19 portal.gov.bw. So in this website, we have various information on COVID-19 in Botswana, but particularly important is the document library. When you click on the document library on that website, you are able to get access to the different guidelines that have been developed so far on COVID-19, and you are able to see them as they are updated as well. So next slide. As you can see, we have different guidelines there on the government portal. So we have ones on contact tracing, the ones that talk about pediatric guidelines, and then there are COVID-19 and pregnancy guidelines, as well as many other guidelines. So if you are interested, please do go to that website and you'll have access to those. Next slide. So on to our presentations today. Like I mentioned, we have presenters from two DHMTs, Mahalapye and Tutume, and we will start with Mahalapye DHMT, who is the acting CMO for Mahalapye DHMT, who has 10 years of clinical experience. He graduated from Monash University in 2019 and has worked in Princess Marina Hospital, Greater Lobatse DHMT, and now currently working in Mahalapye. He's been involved in COVID-19 activities in the district since last year in 2020. So Dr. Kemang, you have the floor. You may start your presentation. Thank you. Dr. Kemang, we can't hear you. Your mic is still muted. Error.
All right. Thank you, Dr. Smith, for the introduction. I hope I'm audible that side.
Error, you are clearly audible.
Yes. Thank you for the introduction. Good afternoon, ladies and gentlemen. Let me start also by appreciating my team here. I'm not alone. I've got some members of Mahalapye DHMT who helped in putting up this presentation. And also our boss, Makosi Silo, who's the coordinator, is also around as part of the presentation. So without any due delay, let me start the presentation. So just to give a brief overview of our district. So Mahalapye DHMT is located in Central District Council. It is part of Greater Mahalapye when you talk about the COVID-19 zones. So its boundaries is basically, you have to the north, you have Mahalapye sub-district. To the south, you have Gauteng district. On the western side is Kemang, and it shares a border with South Africa towards the Limpopo side. So on the eastern side, you have the south west province. So that area which is shaded red, so that's where you find Mahalapye DHMT. So like I said, it's part of the CDC, which is Central District Council, and covers about 16.2% in terms of the surface area. From the 2011 census, the population of our sub-district was 118,875 people. It has 40 villages and a couple of settlements as well, whereby Mahalapye village is the administrative center, which has about 46,418 people as its population from the 2011 census. So in terms of the health facilities, you have two hospitals. You have Mahalapye District Hospital, which is a secondary level of care. And then you also have Safari Primary Hospital. So we do have about 43 clinics, including health posts as well. We also have about 15 private clinics, which we work quite well with in our district. So just to show you our COVID-19 response organogram in terms of organizational structure. So you have our DHMT coordinator, and then we have the hospital superintendent who is based in Mahalapye District Hospital. We have the head of preventive who actually coordinate all the preventive issues, not only COVID, but when we talk about HIV, TB, PMT, CT, immunization, and so forth. And then under him, we have the coordinator, the COVID-19 coordinator. So our COVID-19 response team is basically broken down into about 5 different teams. You have the case management team, which actually take care of the patients. You have the contact tracing team, which is also involved in testing of clients. You have the evacuation team. So the evacuation team, you're talking about the emergency services such as the EMS or our ambulance services, which actually evacuate patients from the community and taking them into the different isolation centers. And then, of course, you have the health education and promotion, which is responsible for dissemination information about COVID-19 to the communities, including also distributing different IEC material. And of course, we do have a vaccination team, which is engaged into vaccination of the community. However, as we all know that COVID-19 rather is not only an issue which has to be handled by the health sector. So we do have a multi-sectoral approach in our district. So we have what we call DIOG. DIOG is the District Emergency Operational Center. And then at the top, we have the DC, or the Deputy District Commissioner, who is overlooking this center, whereby us as a hospital, or rather as a DHMT, we are the secretariat of that commission. And then under it, there are different functions. So you have the environmental health, which deals with clinical waste and disposal of waste. You have the psychosocial support team, which is about counseling in terms of the frontliners who are involved in this work, patients, as well as their families. We also have the logistic teams. So the logistic and communication is responsible for risk assessment as well as analysis. It also responsible for mapping resources. When we talk about transport, they try to source transport from the different departments so that we can all pull resources together and try to fight this pandemic. Also involved in community education as well. And then we have the operation. So operation, basically, that's where we come from as a DHMT, where most of the work has been done. So here you talk about the surveillance, we talk about case management, we talk about contact tracing. We have a committee which is looking up to after the availability of PPEs, as well as the pharmaceuticals that are needed for COVID-19, of course, infection prevention control. So we have a committee which is basically deals with infection prevention, deals with education, all the supplies that are needed. And of course, there is need for safe and security. We have the security personnel, and it is also a branch of DIOC. So that basically the structure at the district level, almost all the sectors or departments are quite involved in the fight against COVID-19. So in terms of our isolation capacity, so we do have two main isolation centers. So we have what we call the Mahalapye Isolation Center, which has a bed capacity of around 68 beds. So this one is where we keep mild patients, those that doesn't really need oxygen support. And then currently the occupation rate as of Monday, it was around 44%. And then we have the hospital isolation ward. This is where we keep to moderate to severe patients. Bed capacity there is 25 beds, and then 20 of which they have the capacity to administer oxygen to patients. So most of the patients, we keep them here, those that are moderate to severe, and then those that need to be referred to another facility. Then our next referral center will be Tutume Masiro Hospital. So as of Monday, we had about 7 patients in the ward. I think about 5 of which they needed oxygen. So that translates to about 28% in terms of bed occupancy rate. So in terms of the epidemic overview of our district, the cases as of Monday, which was the 6th of September, the tests that were done, we did about 65,409 cases, the majority of which is about around 80% of the cases, or rather of the tests, it was done from the rapid test. We do also do some PCR usually for those patients. Maybe you find that a patient is symptomatic and then you do a rapid comes negative. And then those cases usually, because of the high index of suspicion, we end up doing a PCR for them. And we do actually get some positive cases from those ones, even though the rapid was negative. So our cumulative cases, as of the Monday, we had about 10,089 cases, which translates to a test positivity rate of about 15.42. So in terms of the outcome, so from that 10,089, 9,617 had fully recovered. We had about 312 who were still active cases in isolation. And then deaths so far, unfortunately, we have recorded about 157 deaths, which translates to a case fatality rate of about 1.56%. As of those that are active cases, so basically this shows that about 10 new cases were recorded over the weekend that preceded the 6th of September. And then of the 312 cases, 281 were in home isolation, while 31 of them were in facility isolation. So majority of our cases are in home isolation, given the capacity that we have. And then of those that are in home, and then in terms of the quarantine, we have about 104 cases were in quarantine, of which 101, it was a home-based quarantine. we had 3 cases who are in facility quarantine. So the 3 cases that we had in facility quarantine, like I mentioned earlier on, that we share a border with South Africa. So you find that we still have some people who are illegally crossing the border. So therefore, those ones, they are brought to us by the police, and then we have to keep them in facility quarantine as they are still under police custody. So this is an EPICAF and EPICAF, which basically shows the daily trend of our cases. I think from there you can note that we recorded our first case around the 6th of August in 2020. So that's when the start of the first wave. And then when you move around this area, which is around February, following that, which was the festive season, that was the period when schools were beginning to open as well. So we saw a surge in the number of cases. So the majority of those ones were mainly from the schools. So we have a couple of schools which are boarding schools. So we ended up having quite a lot of cases during that period, where we consider it to be maybe our second wave, the period of February going into March. And then from there, when you go into the last month and 2, we also experienced a rise in the number of cases, especially just beginning of June, worsening around July, and a downtrend at the beginning of August. So this is a period where basically it was not us only, but nationally, we saw that peak in the number of cases, and then most probably it was rather the Delta variant. Some districts, they did the genomic analysis, of which the majority of their cases were the Delta variant. For our case, we did do also the genomic analysis, but are still waiting for those results. But looking at the trend, looking at what happened in other districts, most of the cases is more likely to be the Delta variant. This one is basically the same, but this one will be more of a monthly trend. So the beginning of August last year, we had about 5 cases, and then we had a peak of cases somewhere around February into March, and then in the last 2 months, especially in the last of July, that's when we experienced quite a large number of cases, about 3,365 cases in 1 month. And then August, there was a slight drop of about 2,403. And so far this month of September, we have also seen a further drop in those cases. So basically, that has been the monthly trend in terms of cases in our district. Like I mentioned earlier on, we had about 40 villages in Mahalapye, and almost all the villages have reported cases, as you can see from that graph. Of course, Mahalapye, like I said, is the administrative center, which had the largest number of population of around 46,000. And out of that, we have recorded about more than 5,500 cases. And then the majority of the cases where the villages that you see that it has more cases, those are considered to be big villages in Mahalapye, which with more population. When we talk about Shoshon, Ramokonami, Mokami, and Separi. So those are kind of big villages. And obviously you can see that we have a large number of cases in those villages owing to the population in the same villages. And then as healthcare workers, as we are the frontliners, also we have not been spared of COVID-19. So from the graph, you can appreciate the number there that we've already had about 309 cases, which is COVID-19 among the healthcare workers. The majority are the nurses, with 123 cases of nurses being affected by COVID-19, followed by the cleaners, as well as the healthcare auxiliaries. And then 14 doctors were also diagnosed with COVID-19. So when you talk about 14 doctors, that translates to around roughly around 50% of the doctors in our district. So they were really kind of affected as far as COVID-19 is concerned. And 83, and then you also see that mainly, like I said, the younger generations, they're quite more affected as compared to the older ones, the 65 and above. So the older they get, that means the trend was actually going down. When you look at the case, looking at gender-wise, female comparing them to male, you can appreciate from those two graphs that the females were more affected than the men. Could be maybe of two reasons. The first one, in our district, population was from the census that we last had in 2011. We had more females than male in our district. And also one of the reasons could be mainly because of the health-seeking behavior. As you also know that men, they usually tend to have poorer health-seeking behavior. So that could also explain the differences in terms of why the females were more attacked than the males. And then when you look in terms of our mortality, like I said, unfortunately, we have recorded some death. We have recorded about 157 deaths. Our first case or death or mortality rather being October last year. And since then, there have been an increase in the number of cases, or rather of mortality. So when you look around the month of January, February, March there, where it was our second wave, there have been more increasing number of cases, where by March, where we actually thought it was the peak of the second wave, there were 9 cases. And then after that, there was an increase in the number of mortality. And then as we saw from the last slide, that around July, that's where we had the largest number of cases of more than 3,300. And in the first week of August, that's where we recorded more deaths. And then as a result, August, we ended up having quite a large number of deaths, of course, around 600 and around 67 deaths by the month or by the end of August. So September, this month, we haven't had much in terms of death. We've seen a decrease in the number of deaths. Of course, obviously it translates to the same decrease in the number of hospital admissions from COVID-19. So far, we have recorded about 3 deaths by the 6th of September. Yes, by the 6th of September. And then as of today, I think our death for September has been recorded 1 more death. So there are 4 deaths in September as of today. So then when you look at the distribution in terms of the month and gender, so like we saw from the previous slide, August is a month where we had large number of deaths or more deaths. And then as a result of that, that can be translated there. And across board, you can also appreciate that more females were actually affected than male. And then that still correlates with the total number of cases, as we saw that more female pretty much across board, they were more affected. And this, we can see it translating into mortality. So more females died from COVID-19 as compared to males. So this is the distribution of death per age group. So looking at the age group, from the previous slide, we actually did see that we had more cases of COVID-19 amongst the younger people, especially those that were between the ages of 15 and 24. That's where we have more cases, usually owing to the school population. However, when you talk about mortality, the older people were more affected as compared to the younger ones. So we had those that were between the ages of 65 and 75, most of the 47 cases dying from COVID-19, and then followed by those that were 75 years and above. So we recorded 40 cases. So in total, you can see that for those that are more than 65 years old, we recorded more than around 87 deaths in that age category. So this one is basically, we're trying to look at it in terms of the underlying condition, who were more likely to have mortality depending on the comorbidities that they had. So I think the majority of cases you can note from there that died, or the mortalities that recorded, they had one one comorbidity and so forth. So the majority of those that had comorbidities, I think diabetes and hypertension were more cases of death that had morbidities. I think we recorded about 26 cases that, of death that had diabetes and hypertension. So the majority of cases that were recorded in terms of mortality, they had some underlying conditions. Only 34 cases out of the 157, they had no underlying comorbidities. So, so that was basically about the COVID-19 in our district. Just a brief overview in terms of our vaccine. So we have started our vaccine rollout plan. So I think we started our vaccination around the 12th of April this year. And this, our initial plan was to do the 3 phases. And obviously, as you might be aware, there have been kind of a bit of changes in the phases with time. However, the target population still remains the same. So our target population was 93,532. So this is basically, as you saw from initial data set, our population of our DHMT is somewhere around 118,000. So this target population, it was including those that were 18 years and above. So it was around 93,500. So far, we have received about 4 different vaccine antigen in our DHMT. So the initial one that we started with was AstraZeneca, and then both for the first and the second dose, we were allocated 2,370 doses, and we managed to utilize all those doses. So for the first dose, we managed to vaccinate 2,416, and then the second dose, we managed to vaccinate around 2,377. So the majority of the people who actually got the first dose, they did come forth for their second dose. And then as for AstraZeneca, rather as for the Sinovac, we allocated 12,748 doses for both the first and the second dose. And then we managed to utilize almost all of it with minimum wastages. And then we also received the Johnson & Johnson, which was mainly targeting the teachers, and then some few others were reserved for the community. So we received 5,970 doses, and we managed to utilize all of those. We vaccinated 5,981. And then the last antigen that we received was the Pfizer. So for Pfizer, we received 468, and then we have vaccinated 460. So we haven't actually received, or rather they are not yet due for their second dose. So hopefully in the next few weeks or so, we will be giving them their second jab. So basically, looking from that table, so in total, we have fully vaccinated 20,997 out of our target population of 93,532, which translates to around 22.4%. So basically, that shows that we still have quite a long way to go in terms of achieving what we want to call as the herd immunity. So through all this, we have faced some challenges, like all the other districts. Rather, we have not been spared of the challenges. So mainly in terms of our main challenge was lack of transport in contact tracing as well as case management. But however, like I said before, we don't work in isolation. We work together with other sectors. So through the office of the DC of Mortality, we managed to pull our resources together with other departments, and then we managed to assist us with transport. And then the other issue was insufficient of space, rather in terms of bed space for our isolation, especially during the third wave. We actually saw a large number of cases, and almost all our all our beds were quite full. We had some patients who were in the community whom we would have preferred to be in the facilities, but owing to the shortage of bed space or insufficient of the bed space, they ended up being in the community. However, at some point during these cases, we had to utilize schools for isolation cases, especially during the period when the schools were open. So schools liaise with the teachers so that at least we can use some hostels or some classroom at least to isolate the school population, because then we have quite a large number of them, so we can't actually accommodate all of them in our facilities. And of course, shortage of staff. I think this one is cross-cutting across all the DHMTs as a result of just the shortage of staff, as well as staff being affected by COVID-19, ending up having to work with skeletal staff. However, I think what we needed to do, or what we did rather, was just basically try to optimize our resources, try to engage with other facilities which are around us, so that at least we can push staff from one facility to another, just to mitigate this one. So the last slide, I think this is the second but last slide, the achievement that we had, basically, as you said, engagement with other stakeholders, collaboration with them so that we can pull our resources together, and also utilization of our spaces. So we have utilized, or rather we have identified another ward in our hospital, which we want to extend for isolation purposes in case we also see another increase in the number of COVID-19. And then lastly, in terms of our achievement, our vaccination rollout plan, I think, has been successful so far. All the consignment that we have received, we have managed to actually successfully vaccinate our community without any wastages, without any serious adverse events noted. So in terms of the way forward, what we are currently doing is just continue to sensitize and strengthen education for the community, also in terms of emphasizing mainly on infection control, more especially in the schools, because that's where we have a large number of our students in them, and that's where we see more cases, especially when they're open. And of course, engaging with the local leadership, when we talk about the hosts, the councillors, and so forth, the community, they listen to them to more. So time and again, we have to continually update them on where we are as far as COVID-19 is concerned, where we are as far as vaccination is concerned, so that they can relay the same information to the community. And lastly, we have a home isolation strategy that we are working on implementing. So this one is just basically to strengthen home management of COVID-19 patients. So we want to empower and improve community involvement in terms of participation, so that that can ease the burden into our facilities. So with that, ladies and gentlemen, I think that should be my last slide. Thank you very much.
Thank you, Dr. Kemang. Thank you so much, especially for sharing those structures, the DOC and the COVID-19 response organogram. I believe it really emphasizes the need for collaboration in COVID-19 response. So now we'll have a presentation from the Tutume team. The presentation will be by Dr. Charles Madamombe, who is the head of curative services at Tutume DHMT, also the case management lead for COVID-19 and malaria. I'm hearing an echo. Dr. Kayombo, may you mute your mic while I introduce? Thank you. Like I was saying, Dr. Madamombe is the head of curative and the lead for case management for COVID-19 and malaria in Tutume DHMT. He graduated from the University of Zimbabwe in 1995, has done a diploma in HIV/AIDS management from the University of Zimbabwe in 2008. He's been the Director of Medical Services at the Ministry of Home Affairs in Zimbabwe from 2000 to 2008. Has also worked in private practice from 2008 to 2015. Was the Senior Medical Officer at Tutume Primary Hospital from 2015 to 2018, and was then assigned the acting chief medical officer in 2018 to current. So at this moment, I will give the floor to you, Dr. Charles, to give us an update from your district. Thank you.
Thank you for that introduction. I will have to ask someone to move the slides for me because I'm failing to share from this end. But basically, before we go into that slide with the case is Tutume sub-district. The village itself, Tutume, is about 108 kilometers from Francistown. It has two primary hospitals, the DHMT, namely Tutume and Gweta. That's Gweta on the west side and Tutume on the east. Tutume village itself has an estimated population of around 70,000 people, and it serves 18 villages and 15 settlements. On the eastern side, there are many facilities, a total of 33, whilst on the western side, it's a bit smaller with facilities, around 9 facilities. So going into the slides, our cumulative cases as of the 6th of September, there were 4,717 with 8 new cases, 100 active cases. Recovered cases were 4,592 with 25 deaths. Those in our home isolation was 1, and the facility isolation was 1. But currently there are now 2 patients in the facility, and our cases have slightly increased to 4,734 as of today, with 5 new cases. Sorry, I'm still on the previous slide, I haven't moved. And then the recovered cases, 4,620. The mortality remains the same. So we've got, like what I've said, we've got 2 in isolation, and the home isolation is 87. Thank you. Can you go to the next slide? This slide was just showing the number of cases in August 2020 to August 2021. And as you might be aware, Tutume being about 108 kilometers from Francistown gets quite a large population commuting between Tutume and Francistown on a daily basis. But the peaks that we have, if you look at that graph, is from January to February, was mostly related to the interzonal movement, which happened during the festive period. And likewise in April, that rise also was accounted because of the Easter holidays. And then the peak around July, August was mostly due to a high increase in school infections. We quite had a number of schools which were affected within the district. Next slide. And then this one is just to show the number of cases per village. And as you'll appreciate, Tutume is quite the highest number for the reasons that I've just outlined, and Gweta as well, followed by Sewer Town. Sewer Town is, for those who are not aware, it's a mining town of quite young population who are highly mobile between the salt mining town and Francistown and other areas. And Nata was not so much affected, but I think this might have been because of poor reporting on the Nata part, because Nata lies on the A3 linking Maun and Kasane, and there's quite high mobility in this area. Next slide. Looking as per facility, the 2 primary hospitals which are the largest number of patients. And in this, I should point out, these 2 facilities, we have 2 small isolation centers there, which with quite a limited bed capacity. The one in Gweta is got 5 beds, and the one in Tutume has got 6 beds. Marapong, despite being a small village, had quite a high number of disease burden. That was due to the school outbreak, and so in Dukwi as well. And Suwa also had schools quite affected by the outbreak. Next slide. So looking at sex and age, the age which was most affected was from 10 years to 19 years. And sex-wise, there was not much difference, but females were slightly more, maybe accounted by the slight higher percentage in terms of population of females, and also the early health-seeking behavior of females more than males could account for this. But as you go further on in terms of age, you find that discrepancy was not notable at all. Can I have the next slide? Thank you. On this, the positive cases that we had in the schools. And like what I said, it was mostly around the time of July to August. And the schools that were affected, it was mostly Dukwi, Marapong, Suwa, Tutume, not so much. Another area where we felt that it was affected, but the reporting was poor, was Nata Secondary. It was an area where there were quite a high number of cases. This case is, I think these were during the time where there was that social video circulating where school children were really encouraging each other, because we had a situation where they preferred to be in Matsiloje isolation more than to be in school. So this is where we got this quite a big outbreak in that particular time. Can I have the next slide? Thank you. Just to make some comments, there's been 19 new cases, reduction in active cases, and presently we are registering probably 1 or 2 positive cases per day, which is quite a big drop from around July, where the cases were high. We have not, as a district, reported any deaths from July. Our last mortality was on the 30th of July. And our isolation center currently now has 2 patients. Gweta is 0 patients. And since schools reopened a week ago for completing classes, and the remaining classes will open on the 7th, we have adhered to the advice from the DHS that there will be no mass testing, and we'll test as and when there's a need, when someone is symptomatic. We've also engaged the school management to discuss with them in terms of how to keep the numbers low. So there are committees which are running, with headmaster chairing, and with healthcare workers being part of the team to help to keep the COVID-19 protocols. Thank you. Next slide. Okay, before I go to the vaccination, I would just like to discuss a bit on our mortalities. Tutume, on the eastern side, we've had a total of 16 deaths. Of those, 10 were in the facility and 6 were BIDs, which we swabbed upon certifying with 6 which were positive. The mortalities we've had are from around mid-June to end of July. Most of the clients we've had, like in the facility, out of all the 10 deaths we've had, 7 had comorbidity. The most common is being diabetes and hypertension, and one was an epileptic. We had 2 who came in already as home-based care who got COVID was at other comorbidities. And then on the BIDs, they were mostly elderly patients ranging in terms of age from 69 to 100 years who already had other comorbidities. So moving on to our vaccination program. Just a second, I'm trying to view this. Okay. Starting with the group, the 55 and above, our target was 12,118, of which 13,166 got the first dose. And on the second dose, 12,450. This is accounted for the fact that because we are close to Francistown and people found it easier to get vaccinated in Tutume. So we had higher people coming from outside or in our neighboring districts who came in and got jabs from our teams here. With Johnson & Johnson, we've had 358 of those were 55 and above. On the 30 to 54 age group, our target was 22,528. And of that, the first dose, 5,352 received. The second dose, 4,555 received. And on Johnson & Johnson, 4,524 received. 18 to 29, which mostly catered for healthcare workers and police officers. The first dose, our target was 29,247, and on the first dose, 36 received. And so far, they hasn't gotten any second dose. And Johnson & Johnson, 2,419 received. Some of these were the hard to reach area where we, despite the age, we decided when we go there with our mobile teams, we will vaccinate them since the rain is about to start and it's very difficult to transgress that terrain. And so far, the total number that has been fully vaccinated is 24,306 out of our target of 65,054. Can I have the next slide? Yes, making a percentage of 37%. So our COVID vaccination progress by age group so far, in terms of percentages, the 55 and above, you can appreciate because of this, I've already outlined that with people coming from other districts, we actually overshot our target at 105.7%. And 30 to 54, we are standing at 40.3%. In the 18 to 29, it still just started at 8.3%. So far, our total has been 37.4%. And of that, the totally fully vaccinated are 24,306 out of a target of 65,054. Next slide. The progress on the second dose, the antigen. The AstraZeneca being the one that was initially started with, on the first dose, we have 2,839, and you realize that on the second dose, we've got 2,601, making a progress of 91.5. There's been a slight reluctance to get the second dose. On Sinovac, First dose has been 15,593. Second dose, 14,404, with a percentage progress of 92.4. Pfizer, as you are aware, initially came targeting our police officers and people in the security sector. We had the first dose 122, and I think some of our doses we had to give to Greater Francistown. On the totals, we are standing at about 92.5 in terms of progression to the second dose. Next slide. Looking at the ages, I think it confirms what I've just said. 55 and above, they are totally vaccinated at more than 100%. The healthcare workers, they are standing at about 66%. Which interestingly enough, you would have expected that to be 100%. But I think amongst us healthcare workers, there's a bit of antigen apathy. Then on the 30 to 54 age group, we are standing at 40%, and 18 to 29, which have just been studied on the hard to reach areas. Can we go to the next slide? The challenges that we've faced as a district, I think some of them are common to other areas, is the shortage of the RDT kits, which we have 48 in stock, with a promise of receiving 30 from the National Health Lab. We've also had inadequate isolation space. Like previously stated, TPH Tutume Primary Hospital has 6 beds and Gweta is 4. Despite us having had a common understanding with our neighbors, that is Northeast and Greater Francistown, there's always been a challenge in terms of logistics to refer clients to our neighboring districts. Even more so, if you have to refer a critical patient to SKMTH because of the issue of flights and other related issues. And naturally, this led to a poor outcome. I think recollecting on our referral to SKMTH, we sent 4 patients, of which 2 passed on and 2 made it. The other challenge is also common to other districts in terms of the issue of human resources, and also the issue of even having staff, but in the skill set to manage COVID-19 patients being limited. What we could only talk about is we managed to send 2 clinicians for a rotation at SKMTH, and they've been assisting us greatly in terms of patient management. We have also had shortage of transport like other districts when it comes to the vaccination campaign and call outs and contact tracing. The communication challenges has always been quite an issue because we have not had any operating call center, and cell phone we've been allocated with one from the national program when the COVID started. Unfortunately, this handset came without airtime. Next slide. And Tutume is a challenge in terms of the internet connectivity. And this is in hampering our vaccination campaign in terms of patients registration and also reporting. And then the other challenge which we are also facing, there's a lot of vaccine apathy relating especially to the second dose, not knowing whether this is related to the after immunization events or other issues. Next slide. we have scored some successes, I think one of which is good vaccination coverage. We developed initially a good capacity of testing, training all our HCAs and EHEAs to test so that our clinicians can concentrate more on their core duties. There's also been continuous health education at every opportunity in the facilities, in the workplace, in churches, and in the quarterly meetings. We are currently at quite an advanced stage in terms of setting up a mobile team that will be responsible for triaging and reviewing patients who are in home isolation. And transport situation has improved greatly through the Mlaudi, with other departments chipping in with their own vehicles and drivers. And also another strength of success, there's been quite good teamwork and great working relationships with our sister DHMTs, especially in terms of oxygen supply shortages and referrals. I think I'm coming to the end. Thank you very much. Thank you. Thank you.
Hi, thank you. I
right.
couldn't unmute my mic for some reason. Thank you so much, Doc.
Okay.
Irra. It's very nice that you even mentioned the successes from your districts as well, not just the challenges. And I appreciate that you also touched on the vaccination progress to see where your district is, because currently that is our biggest intervention apart from the COVID-19 protocols that we are doing in the community as well. So at this time, we're slightly out of time. The time is 5:04, but there is a question on the chat. Dr. Rosatla wants to know from Mahalapye, what needs have you brought together for the proposed expansion of the isolation center?
No, thank you for the question. I think as for our isolation center proposed expansion, I think I remember it as well during the month last month when we had basically an occupation rate, especially in our main and our isolation center where we provide oxygen. You find that our bed occupancy rate will be more than 100%. So, and then in our district hospital, we do have a unit which is called the TB ward, which is mainly for admission of TB cases and so forth. However, in that ward, the bed on average per month, maybe you have about five cases. So we noticed that it was quite underutilized. So it's a 24 bed unit with 12 units for males, 12 units for females. So with that one, the main needs that we had obviously were the staff. So we needed more staff. So as far as staff, like I said, we have a primary hospital, which is Safari. So we liaised mainly with Safari in terms of trying to pull the resources together. And they did release a couple of nurses to come and mend the isolation center. And then from our hospital in Mahalapye, we tried to merge also some units so that at least once we have made 2 units, at least we can take some of the nurses to go and mend that other unit. And then the other thing that we need, obviously, we still do admit TB patients, like I said, around 5 a month. Some of them obviously will be MDR cases. So with those ones, then we have to liaise with other facilities like Marina, who they had a TB ward where we have to send the patient that side. So those are the main needs that we needed to put together, because otherwise it was an already functioning unit which was admitting patients. So everything was quite well in structure. Like I said, it was a 24 bed, 12 for males, 12 for females, and then each side had about 8 oxygen pod, so which actually we'll have an additional 16 oxygen pod in case, who knows, maybe we get more cases of COVID-19, so that we don't overcrowd our patients like we did during the peak of the third waves. Thank you.
Thank you, Doc. And like I mentioned at the beginning of the webinar, the purpose of really having these updates is to learn from each other. So as you're talking about liaising with other facilities, I think other districts as well who are facing the issue of lack of staff and lack of bed capacity, that's something that they can look into as well. Any other questions from the floor? Okay, we have a hand from Dr. Clement Mokadi. Dr. Clement, you may unmute your mic.
Okay, thank you very much, all the presenters, Mahalapye and Tutume, for the interesting presentations. I have one question to, okay, let's say to all of them. What is from their data analysis? I remember the vaccination started earlier May, and that's when we started the AstraZeneca. And the targeted group by then were those above 65, 75, just let's say above 55. But from the data analysis from Mahalapye, I've noticed that they've lost more clients. More deaths were among those who were above 65. So was there, which actually looks like opposite to some of the districts, like our district and even national level. You feel like the above 55, the mortality is reduced compared to other age groups. So what will be the reason why there are more mortality rate in this age group above 65, while they were the first target during the vaccination of AstraZeneca and even Sinovac? That is one. From the Tutume, I did not get the case fatality rate. What is the your case fatality rate? I mean, in average from the beginning up to now. Thank you.
Okay, thank you so much. Let me give the floor first to Tutume. And if we have time, I will give Mahalapye. Yes, Tutume. Your case fatality rate.
Hello, thank you for the question. I was saying it's very difficult. Can you hear me?
Yes, we can hear you, Doc.
Yes, in terms of most of the mortalities that I reported on, they are on the eastern side. So like what I said, we're 10 in the facility, 6 BIDs, and Gweta, to my knowledge, I think the 2, and 2 were from Horo and Marapong. Yes.
Okay, I think the importance really of knowing the case fertility rate, it will help you maybe to look at your case management that side, to say if you have diagnosed 10 people and 6 die, then there's need to look into the case management. So I think that's something that the team can look at and see where you are as a district. And then for Mahalapye, there was a question as to why the higher mortality in the elderly, but what I realized is Tutume is also facing the same thing. And what Tutume had said was it's mainly people with comorbidities. So I think that's the huge contributor to that, is because the elderly tend, although they are the ones who were the first targets for the vaccination. I don't know if there's any other question. On the chat, there's just a comment from Dr. Mugadi. Thank you, Mahalapye, for an interesting presentation, and from Dr. Ombe has communicated to say they are I've since but thank you so much to the presenters, and thank you to all the participants who took that time to attend this webinar. These webinars are really made successful by you, the participants and the presenters. Without you, the organizers, we are just, there's no use to these webinars. So I think Vusi, you may take over and tell us about next week's presentations.
Thank you very much. We have lined up for next week MRI Botswana. We hope they'll be able to come through to share with us how they have been doing in the emergency care area.
Okay. Okay. Thank you so much, everyone. Please do join us again next week. Same time, same place. Good night.